Thank you very much. It's always a pleasure to work with Jeffy. You're not only learning about medical research, but also the definition and spelling and English. It's just so wonderful. So today I'm going to tell you a little bit about why children are at higher risk or greater risk of medication errors. And also to describe a little bit about the epidemiology and the nature of medication error. And also I want to say some what I call 5 risks. It is, from my perspective, why we make mistake or why we have error, why we have higher risk. So we go back to a systematic review we done a few years ago, looking into the epidemiology of it. It's just quickly to just tell you, if you read the literature about medication error in children, you will find it so confusing. Depending on which paper do you read, you will get almost completely different answers. You will find that the prescribing errors anything between 0.45% to 30.1% per 100 orders in America, because majority of the research were in America. And also, you're looking into the drug administration errors between anything between 0.6% and 27%. Again, so you can see there's a wide variation. But why? It's simply because I think Jeffy beautifully illustrates everyone using different definitions. When we use different definitions, obviously we get different outcome. But what I want to point out is the error rate, no matter what way you're going to look into it, it is not small. We still actually found that quite a lot of error in children. And indeed, it's quite clear that the error that we make in children is no less than the error we make in elderly or adults. So that is an important point that I want you to take home. Children medication do make error. And also one of the important things that make pediatric medication errors different from other errors is we commit a lot of what we call the tenfold error. We tend to do a lot of calculation error and also the dilution error, causing the tenfold error. And unfortunately, this type of tenfold error could be very, very, very severe and sometimes even lethal. So today what I'm going to do is I'm going to give you different cases. I'm not going to give you a lot of epidemiology. It's not much point to tell you that we have a lot of error. But I want to use different cases to help you to understand why we make the error. And hopefully, particularly, help our colleagues in industry and the regulatory authorities to understand why this type of error happen. And hopefully, when we design the medicine or when we actually have the guidance to help people to use medicine, we can think about it. So how big the problem? We did a study in the UK looking into some of the word that we have. And of course, Jeffy also mentioned about the definition of error. So we did use our own definition. We did do a Delphine study to define our definition. And what I want to point out is we do get quite a lot of error. But of course, as Jeffy also mentioned, or David mentioned, a lot of error do not actually cause harm. Some people quite alarmed to see this particular picture to show that we have a lot of prescribing error. So we're talking about anything between 5% to about 30%. And of course, what we meant by error is also including some of the things that, for example, if people, they put down 200 milligram salbutamol inhaler, you can't give it because there's no such thing. So you can't really give that amount of salbutamol to a child. So that kind of error will never really cause harm, but we do have this type of prescribing error happening. And of course, we also have what we call the administration error, but depending on how you define the administration error, you can define not washing the hand before the preparation is a problem. You can also define, use the wrong diluent is a problem. Of course, most of those errors are not going to cause a lot of harm, but occasionally we see some very serious error. For example, in this particular study, we saw a child supposed to be on 32 milligram phenytonin, but actually was given 320 milligram phenytonin. And that was on a Sunday. So the kid actually received the medication. But thank God, that particular Sunday, this is the first dose. If the dose was given on Saturday, it means that Sunday we'll have another dose. Then the kid will not be able to cope with the overload of the phenytonin because of the zero order pharmacokinetic of phenytoin. On Monday morning, when the pharmacist went to the ward, the pharmacist noticed it was wrong, stopped the treatment immediately, put the patient on monitoring. Of course, in this scenario, it hasn't done any serious harm, but potentially one more single dose, we are going to see a very nasty effect in this particular patient. And also we have another kid supposed to be on, when they do the calculation on the trimethoprim as antibiotic, the calculation is not only 10 times overdose, but for this particular case, the trimethoprim is actually 10 times underdose. We have the situation when we have 10 times underdose of antibiotic, it is not going to work and enhance the resistance. But you're not going to see the immediately problem. So what I want to point out is we do a lot of this type of calculation, 10 times overdose or underdose. It may not see immediately the problem, but if it continue to be like that, there will be cases going to cause serious harm to the children. So why children at a higher risk from medication errors? First thing is drug dose tend to calculate based on patient age, sometimes patient weight, sometimes patient body surface areas. But indeed, if you take some of the medicine, particularly sometimes like the chemotherapy, if you use 3 different ways to calculate it, you actually get 3 different doses. So it's not as simple as a lot of things that in adult that you give a tablet or you give a capsule. But in children, you do need to do the calculation. And it doesn't help is particularly for the younger age group. When they grow older, the infant grow a bit older, the weight change significantly, and you need to recalculate it. And the third thing is inadequate information. We already know a lot of medicine never been tested or licensed in children. So there are a lot of problems. We do not know a lot of information. A lot of time we have to make our own guess or try to look for the information. And sometimes the SPC basically say, do not use in children. It doesn't help, isn't it? Because we need to use in children. Inadequate availability of appropriate dosage form or concentration. And that is another major problem. I'm going to show you the cases. And finally, it's a fewer internal reserve to buffer any medication errors which may occur. I'll give you an example of, we just mentioned about the phenytoin. 10 times overdose in a child is not that difficult. But 10 times overdose in an adult is very, very, very difficult. Once I was working in a dispensary a long time ago, somebody was doing a calculation of acetylcysteine for paracetamol overdose. And she did a calculation, she required 100 ampoules. And she tried to find 100 ampoules in a dispensary. David already shook his hand, which was impossible. We never stocked that much of acetylcysteine in the pharmacy. Immediately, you ring the bell. You cannot administer 100 ampoules in anyone. So obviously, this person 100 times overdose. But in children, 100 times overdose is not that difficult. In adult, you almost have to murder somebody to inject 100 times overdose of injection. I'm going to show you cases later. So, but what I want to show you is error can occur in different stage and also can happen in almost everyone. They are involved in giving medicine, prescribing medicine. So the first one is prescribing. This time I make a difference. I usually use physician, use doctor, but this time I decided I use an oral surgeon instead. Since one of the physicians already admit, doctor make mistakes, so now this time I use a dentist instead. So this is a case in America. It's actually this particular young man, Michael. Michael is a 15 years old boy, and he had learning difficulty. He had ASD, autism. So he couldn't communicate. After the tooth extraction, it was difficult. So the dentist thought he can't swallow and he can't talk. Let's give him a fentanyl patch. A patch, give the patch so gradually diffuse the fentanyl into the body to stop the pain. Excellent idea. So the dentist picked up the pen, prescribed it. They went to the pharmacy, got the patch, and put the patch on the body. Great, everything fine. And poor Michael was found dead the next day. Because fentanyl is a slow-release preparation, the drug continued to diffuse into the body. The pharmacokinetics continue to build up the level and continue to go up and go up and go up and go up. In midnight, he suffered a respiratory depression. And what we learned from this whole scenario is the patient actually had high risk because the patient can't communicate. Second thing is the dentist actually never prescribed fentanyl patch in his whole life. He never prescribed it. And he also prescribed the highest strength that he can lay his hand on. And on top of it, fentanyl should only be used in patients that already on opioid, morphine or any other thing. So the whole case, the whole situation, the pharmacist didn't really check the prescription to see whether the fentanyl is appropriate for Michael. So we can see all the mistake happen in this scenario is one thing that is I always think is very important of any prescriber. Always remember, if you don't know the drug, don't prescribe it. It seems to be a very common sense, but my colleague in Arrow Park Hospital, Neil Cowell, he actually demonstrated in a pediatric ward, 25 drugs contribute to about 80% of all the prescribing. So it means that any single doctor work in that ward, if they know about that 25 drugs, they can prescribe 85% of the medication without any problem. But that other 15% drugs should be used by people they know the business. So that is the first thing I want to tell. It's about people don't know the drug, do not use the drug. And in pediatric, a lot of time, they may not know the drugs at all. So second one is transcribing error. That is another case, it's a very sad case. This poor baby have Down syndrome, require furosemide. And the baby was given the furosemide, and the mother know it's 5 ml, give 5 ml the liquid will be appropriate. So, but baby found it's very difficult to give the medicine to this baby. So they decided to make it a bit more concentrate. And the receptionist got the information and put into the computer and override the computer. The computer actually gave the warning to say that maybe too much dose. The receptionist actually overrode the computer warning and still prescribe it. And then the GP, we do not know why and how. The GP didn't check it. The primary care physician in England didn't check it, signed the name on it. And the prescription was given to the community pharmacy, community pharmacist, technician. The technician checked with the hospital, checked with the doctor, the technician in the pharmacy checked with the surgery, but the one who answered was a reception. So the receptionist actually said that's fine, and the pharmacist didn't check whether the technician was talking to the doctor. So happily to give the prescription now. And it was wrong, the whole thing was wrong. The baby had 2 doses of 5 ml of 10 times more concentrate furosemide. And the baby rapidly dehydrate and subsequently have septic shock, admitted to hospital. The hospital didn't realize it, continued to give 2 more doses. And subsequently, the baby died, have convulsion and the whole thing, and the baby died. So the whole thing we're looking into it is, for this particular case, we can see we have people that they are untrained about medicine. They can actually access into our electronic computer system to do the prescribing. And we have pharmacists highly trained without actually taking the responsibility to check whether the prescription is appropriate. If it is an adult, you are not going to make a major problem because 10 times overdose an adult on a standard tablet. It means that the patient have to take 10 tablets of furosemide, which is no one will do it. They immediately will know it's wrong. But in children, in baby like that, no one can understand and figure it out. So next one I want to talk about is the dispensing. Again, we have called it, nurses told us, nurses make mistake, physicians tell us make mistake. Of course, pharmacists also make mistake. We all know that everyone actually make mistake. This particular case was a very sad case. It's a peppermint water case. I'm going to make it very simple. It's basically a trainee pharmacist didn't realize a concentrated chloroform water is different from a double-strength chloroform water. It's supposed to be, the concentrated chloroform water is supposed to be diluted 20 times. But he thought it was a double-strength chloroform water, so he only diluted twice. So it became sort of like over-concentrated. And this peppermint water was given to a baby. Again, the baby suffered a respiratory arrest and died. And one of my colleagues was worked in that particular hospital, and he told me that he actually saw the father afterward because the father tried to do the mouth-to-mouth resuscitation, and the father's mouth was burned by the chloroform water. So it was so severe. So again, what happened is because these trainee pharmacists didn't understand the instruction, how to prepare the medicine, and the pharmacist supervised it, didn't actually supervise it properly. So the whole mistake made. And also another thing that I don't think anyone else actually ever point out, there wasn't much evidence of peppermint water actually working in baby to relieve the colics. So sometimes we prescribe something we don't have much evidence, but we need to consider we don't have evidence they're working. Why do we prescribe such a high-risk medicine to baby? The administration error, this is a nursing error. It is the digoxin. Basically, the baby is supposed to be on 22 microgram. But unfortunately, when the first nurse did the calculation, it was 10 times overdose. The second nurse did the checking, it's still 10 times wrong, and they both checked their own calculation, and they thought they were right. And they both thought they were right, so they administered the digoxin 10 times overdose. And when they gave the evidence to the coroner, they actually said they both thought they were right, and they didn't have any doubt they were right. And that's why they administered the medicine. And then subsequently, of course, the hospital realized it. In the procedure, they need to make sure the labeling of digoxin have to warn people, and also they agree that pharmacists should check the calculation of every single digoxin in the future. So I just want you to be aware, mistake can happen at any stage. Everyone in it will make the mistake, like this particular one, with school rather than school. So it's a fun thing to say in here, but in reality, in pediatric, just one single zero more can be lethal. Yeah. So when we make mistake, we admit it and correct it and learn from it immediately. So this is the last bit summaries. I want you to have a take-home message. This is my take-home message. From my own research experience or from my own working with the children, I found there are something is very high risk. It's high risk of pediatric groups. They are particular. Neonate is the highest risk of pediatric group that when you design any medicine, or any medicine could be used in neonate, be aware. And learning difficulty, oncology patient in pediatric, high-risk drug group, analgesic, anticonvulsant, or any high-potent drugs, particularly a drug that they require very small dose and very easy to do the 10 times calculation wrong. Any high-risk pharmaceutical formulation. When we need to use adult formulation for children use, it's always ring the bell, be careful. And IV preparation, unlicensed products. Unlicensed product, what I mean unlicensed product is not just off-label. It's literally the product produced in a pharmacy or produced by a special company. Because this time in this pharmacy, they can produce in this strength. Next time you go to another pharmacy, could be completely different strength. And I've seen that kind of error many times. And high-risk healthcare worker, it may be funny, I put that unqualified. We saw it already. We have receptionists can actually put the data into a computer record. And we have inexperienced worker like the trainee pharmacists. We have newly appointed and patient and healthcare worker very tired. They are high risk. We need to be aware of it. And finally, it's high risk is changing care setting. We've seen many medication error when a patient change from one ward to another ward, or discharge from hospital to community, or the other way around, from the community go into hospitals. We need to watch out of all those high-risk situations, particularly in children. As I said before, in adult, it is very difficult to be 10 times or 100 times overdose. But in neonate, in children, it is quite easy. So we need to remember, we don't make mistake twice. But of course, we know that some people, they make mistake 4 or 5 or 6 times. And so we find the problem, we change it, and hopefully we do better. And finally, I just want to flag it up. A GRIP is a global research in pediatric network. We try to do our best as a group of pediatric researchers. We're looking into how to make medicine better in research side of it. We welcome anyone that have any suggestion for the research agenda for us. By all means, to contact me. And thank you very much.
Right, thank you very much, Ian, for this very lively and realistic talk presentation of all the specific and high risks of errors, pitfalls that we can encounter during use of pediatric medicines. Are there one or two immediate reactions, questions, comments to this presentation? If not, then I
I'll
would...
just add a quick
Oh,
question.
okay. Right.
Ian, I just wondered, in your experience using parents, the family, in helping manage the risk of medicines, because some of these unfortunate cases are children who are chronically ill, and therefore the families are surely involved in helping the medication. What's your experience in helping them manage the risk?
Actually, if we educate the family better, can actually prevent medication error. There was a very interesting case. This particular child was admitted to a hospital in Birmingham, and the nurse was going to administer the insulin. The insulin was actually 10 times overdosed. But the mother actually noticed it and told the nurse, you are 10 times overdosing my kid. Because the mother actually know all the treatment and everything. And I think from our point of view is we should engage the family as much as we can, and also to explain why you use this medicine. The case about the fusilmide case, actually no one ever told the mother, we are going to change the medicine to 10 times stronger, and please give 10 times less. So no one actually told her. That was in the coroner report actually point out.
Okay, thanks very much, Ian.